Okay, why don't we go ahead and get started. Welcome everyone to our Thursday conference. And before I do that, I just want to put in a plug for our event on May 18th where Dr. Kevin Johnson is coming to show his documentary film on health information exchange, and there'll be some discussion after that. Today, as you know, and you've heard me say, occasionally we devote these conferences to specific types of events. So today is one of our clinical informatics grand rounds that comes out of our clinical informatics fellowship, which is one of the two fellowships we had. And actually, the rest of you would probably be happy to know that for the last couple months, particularly the last few weeks, Catherine and Andrea and Shannon and Karen and myself have been working hard on the competitive renewal for the NLM training grant, our other fellowship. And it went in its full glory of 423 PDF pages. Hopefully no one will print it. But anyways, we feel like we did a good job, and we did everything we could to achieve competitive renewal, which we'll find out about in the summer and the fall. Anyway, so our speaker today is one of our first two fellows in the Clinical Informatics Fellowship, Dr. Jim Morrison, who most of you know from around the department. Jim hails from the state of Michigan and did most of his education, or actually all of his education there, starting with bachelor's degrees in computer science and computer engineering at University of Michigan, going to medical school at Wayne State, and then completing a diagnostic radiology residency at Henry Ford Hospital, where he was also chief resident. Eventually ended up at OHSU in interventional radiology at the Dotter Institute, and then almost by accident kind of found out about our new fellowship, and everything worked out just fine. And he and In-Ho Kim have been our first two fellows, and 3 new fellows will be joining us on July 1st in that fellowship. Anyway, so Jim is going to report on a quality improvement project that he does, that the clinical informatics fellows do as part of their projects, and so as part of their fellowship. So I will turn it over to him. Oh, and for those who are watching out in cyberspace, if you want to send a question about the conference to Jim, hashtag #DMICEConf.
All right, thanks, Bill. So I'm going to talk about quality improvement project that I've been working on pretty much since I started fellowship last July. I call it automating EHR data collection and extraction for a multipurpose data registry. I don't have any financial disclosures, and Vishnu asked me to put some learning objectives together about a half an hour ago. So on the spur of the moment, I said, understand the need for clinical data harvesting, and then discuss strategies, or at least the strategies that I've tried to use for harvesting clinical data, including I'm going to talk about my current solution. So a little bit of background, some context, just introduce you to interventional radiology if you're not familiar with it, why we're different, why we need data, the data that we create, and how are we trying to harness it. So as Bill mentioned, I made my way to OHSU as an interventional radiology fellow. And just some background, since we're all OHSU employees. Charles Dotter was the department head of intervention, or of radiology, and he's actually he was the first person to do an angioplasty, and so he's the father of interventional radiology. And if you've ever driven past the VA, you'll see this little weird-looking house structure that says Dotter Institute. That's our research lab. So if you've ever been curious about that, that's why it's there. So this is the birthplace. And if you go to the 11th floor of the hospital, there's a big plaque that commemorates Dr. Dotter and his accomplishments. So what do? Basically, we use imaging technologies to do minimally invasive surgery. So we use catheters and wires through blood vessels in the body to do things like what I have pictured here. So the image on the left is actually an angiogram, and this is in the aorta. And this patient has developed a hole in between his aorta and his esophagus. So these are blood vessels, and this one in the middle, that's actually his esophagus. So that's a bad situation. Right here we have a stent that's in place before it's been deployed, and then the image on the right is actually a CT scan after it was deployed, and you can see the stent's outlining the aorta, and it's covered the hole and stopped the bleeding. So that's just kind of an idea of one of the types of procedures that we do. To set up my talk, I picked a couple of cases, additional types of things that we do, probably two of the most frequent procedures that we do in interventional radiology. The first one is placement of central venous catheters. So case one, I'd say, is a patient who came to us. He got a tunnel dialysis catheter, and after placement, after he's had it about 10 days, the placement area is red, it's warm, he's got a fever, he's not feeling well, and it turns out this line is infected. And that's a big deal. Anytime an implant in the body gets infected is a big deal. And it's a big deal across the nation. In fact, catheter-associated bloodstream infections has been kind of one of the main things that has been identified for quality improvement, trying to reduce the rate of infection of catheters in the body. And case number two is something that also happens quite a lot. A patient has an operation, in this case, something like appendicitis. He gets an appendectomy, and a couple days after his surgery, he develops an abscess. And the traditional way of taking care of this would be to take him back to surgery, open it up, try and get all the pus and infected fluid out of there. And what we can do in interventional radiology is just stick a needle and a catheter in place. Don't have to take the patient to the operating room. It's all done image guided so we can see what we're doing. And it's done very safely, and it's usually a quick and easy procedure in comparison to a big surgery. So we'll come back to those in just a little bit. So what kind of data do we create? Basically, there's two kinds of data. One at the top here is in the EMR, we create clinic notes. We see patients in the clinic before and after surgery. And we create procedure notes anytime they have a procedure. And then a little bit different, after each procedure, there's a dictation that is created, and that goes into the PACS, which is the Picture Archive and Communication System. So it's actually separate from the EMR. It's a separate source. It's a separate database, a separate source of data. So those are the two main types of data that we make. How do we use that data? Well, we use it for case logs. So every fellow that goes through an interventional radiology program makes a case log, and you need it for graduation. We use the data to create patient or disease-based registries. And as silly as it is, most of our registries are just Excel spreadsheets, which are kind of hand-curated by nurses or physicians in the department. And then we also use the data for research. This is a picture of an access database, because in our department we have a couple of access databases which are used to collect data about patients and use that to help us do research on outcomes. So kind of the question that led to this quality improvement project is, how can we build a system that satisfies all our needs, research, education, operational, while minimizing the impact to workflow and harnessing kind of existing technologies. This is my experience, and there was kind of three trial and error systems that I went through. One was a proprietary system I've made myself. One is an open source solution that I considered but never actually implemented. And then the final one is going to be the solution that I'm using now. So for data collection, one, you can do it by hand, and we already do this. The fellows, like I said, we already transcribe each case that we do into a case log. Yeah, in order to graduate from a fellowship, you have to have logged at least 800 cases. And so my first idea was, can I take this, just make it electronic, make an electronic case log, and instead of writing it down, people would log this into like a website. And that was pretty ambitious, especially I was trying to do this at the same time I was doing my interventional fellowship, and it was a bit too time consuming to actually make a workable system. So instead I created something I called the venous access tracking system. I just selected one type of procedure. In this case it was that central line placement. And I built a system. The diagram, kind of schematic of the system, is on the right. It's a Node.js system with a MongoDB database, and it has a web front end where we can log the catheters that are placed in the department. And then we actually, at the time, we had a medical assistant who was using the system to go back and log outcomes. So she would go back in a patient's record after placement and say whether the catheter was infected or if there were any issues with it. And the screenshots to the left, they're kind of hard to see, but it's basically just screenshots of the application and use. So you can log each catheter that's placed. You can browse through all the catheters that have been placed. It would automatically prompt after a certain time period for catheters that needed to be followed up on. And then down on the lower right is kind of ahead on-demand analytics. So you could see which types of catheters have been placed and how frequently and how frequent was the rate of infection. And then the medical assistant left. So then we kind of lost our person on the ground that was using the system. So that was the kind of proprietary system. The biggest problem with that is it's adding additional workflow in that, or it's replacing a hand workflow with an electronic workflow, which wasn't great because it wasn't a great workflow to begin with. So I was trying to come up with a better way to do this, something that would be more automatic. And one thing that is created for every case that's performed is a dictation. And it has a ton of information in it, which you see listed here. And after every case, an attending will dictate this. That's what's used for billing and coding. And so it seemed like a very rich source of information. And I have a colleague at another institution that had built a radiology reporting database in this schematic here. So basically what we have is, as I mentioned before, there's the PACS, which is our radiology database. There's the EHR. And then anytime a report is created in dictation software, there's communication that happens. That report gets sent to the EHR, it gets sent to the PACS system. And it does that using an HL7 feed. So Health Level 7 is a secure communication standard for passing things like reports between these systems. And there's a piece of software, free software, open source software called Mirth Connect that can sit on an HL7 network, and it can identify particular types of information. Specifically, it can tell you this is a radiology report. And so using a technology like that, you could pluck the radiology reports off the network, put them into your own database, index them, search them, use natural language processing to try and get information out of the text. And so that was my idea. I knew that had worked at another institution. The Radiological Society of North America actually has standardized reports. So in order to try and get information out, best to use a standardized template. Problem with this is it's hard to get attendings to change habits. It's also, there's a lot of overhead building that system. I have to get approval from the hospital. I have to find a place for it to live on the network. So basically there was just too much overhead with this particular solution. As much as I'd still like to build a radiology reporting database, because I think it's a rich source of information, I haven't gotten there yet. So actually I was presenting that venous access tracking database at the Society for Imaging Informatics and Medicine meeting. And a guy came up to me after the meeting and he said, you know, you can do this in Epic. And I said, I didn't know that. And so he explained to me how this, he was from the University of Texas Southwestern, and he explained to me how they were doing it. So do it using the EMR. And as it turns out, you know, the workflow is already in place. After every procedure that we do, we create a post-procedure note. That's kind of the drop-in template that we use. And anywhere there's 3 dots, you can tab through those fields in Epic. So the fellows place a note after every procedure. It's a standardized template. And so what I wanted to do is take that template and be able to grab that data from each one of those procedure reports and then use that as my database. So Epic also provides something called smart data elements. So they're customizable data elements. They can be built into a template just like I showed you. You can grab text. You can do specified categories, numbers, dates, and times. It's searchable. You can either do the search through Epic's production system, which works off a translational database, and then, or you can pull that information out from the relational database, Epic Clarity, if you're familiar with that. And in fact, there's just one big table in Clarity, which is all the smart data elements. So it makes it easy to get that information back out of the system. So I built a smart form. Like I said, I started working on this back in July, and I finally have my smart form built. And if you notice, it's very similar to the procedure note that we were already using. Instead of just having kind of fields to tab through, there's set fields and buttons that you can click, and standardized fields. And each one of these fields actually becomes a capturable data element, which is automatically integrated with our EHR. And when a procedure is performed, you fill this all out, and in the end, it gives you a note that looks pretty much the same as it did before. So, reporting. Haven't gotten there yet. My smart form just went live yesterday. So, the first time I used it, it's working, but the information is actually being saved and stored in Epic. But reporting is coming soon. So, two types of reporting are possible. As I mentioned, there's the production version of Epic. It uses this transactional database. It's very quick. It's actually the same type of database that's used. It's the underpinning of Vista at the system that's used by the VA. It's good for operational reports. It's good for quick reporting. It uses a tool called Reporting Workbench, so you can grab information very quickly from the last week or last month. It's a good solution for a case log if you want to just go back and quickly see what have I done in the last week. And there's also reporting that can be done from the data warehouse. So this is the kind of reporting that is done through the, well, it's done in various areas of the institution here, but I rotated with the reporting group at ITG, and most of the reporting that they do actually comes out of our data warehouse, which is a little bit different. It's a relational database. Every night they take all the information that has been added to Epic in the transactional database, and they move it over to Clarity, which is this huge relational database that has thousands of tables in it. But it's really good for long-term reporting because all the other information is stored. And as I mentioned, there's just a huge table of all these smart data elements. You can grab all the information that you want. And so it's really good for kind of research or educational reports. If you want to just look at patients that had a particular type of procedure over, the last 10 years, you could do that. This is an example of a reporting workbench report that just shows all the, I just ran this really quick. It shows all those types of notes, the post-procedure notes that I personally put in the system. And then this is an example of like a Cognos Clarity reporting, or a report built around Clarity that looks at turnaround times for surgical cases. So why is this important? Well, the idea is that by putting these structured data elements in with the post-procedure note, it kind of lays the infrastructure for future quality improvement efforts. So when somebody has a procedure, it's now it's in the system at this date and time. This happened, and anything that happens in the future, it's really easy to go back and reference that. So you can look at things that aren't in the post-procedure note, like labs or other imaging studies that were done, and you can relate it back to that point, that date and time when that procedure happened. In addition, what I'd like to do in the future is create more of these smart forms with structured data elements that would tie back things like outcomes for procedures. So we follow up with patients after they have a surgery, and 3 months, 6 months, 1 year afterwards, if you just have a more structured data that you can associate with the original procedure, then you can really get some powerful information back. So it also gives us a better map of activities in the department for resource planning and allocation. As ridiculous as it seems, we actually have no way to know what we did in the last month, how many procedures we performed, what kind of procedures they were. So this is part of the solution to answering that, is actually being able to say, well, we're doing, you know, X number of these procedures versus Y number of these procedures, and we don't need to keep, you know, certain types of catheters and wires in stock because we just don't use them that often. And then last but not least, takes advantage of work already being performed. So like I said, this is, after every procedure that happens, a fellow will put this note in the computer, and then at some other point in time, he'd have to go and document it in his case report. And then if he's doing a research project, he might have to go back and do chart review and find, you know, the same information. So this actually kind of consolidates that, reduces some of that redundancy. Instead of having to, you know, manually write all these things down, he can just run a report and get his entire case log for the year, which as a past fellow would have been very nice. So back to the cases. So case one was that central catheter placement. And as I mentioned, central line associated bloodstream infections, major source of healthcare related infections. You know, I built that venous access tracking database to try and help us know how often, you know, what is our rate of infection, what is our outcomes for patients with these. So it's, you know, this system will replace that. It provides a baseline for kind of longitudinal tracking. And new catheters are invented, catheters that are supposed to prevent infections. So knowing which catheters are placed in which patients, we can actually look at outcomes and see if new types of devices are safer, have a lower infection rate. Case two, that was the abscess drain. So with this type of a system, we have an ability to identify and summarize the procedures performed. And as I mentioned, we really didn't have a way to track what types of procedures are performed. If you're an outpatient, you're coming in, your name is on the schedule associated with the procedure. But that's about half the work that we do. The other half of it is inpatients, and most of these post-surgical patients are inpatients. They're unscheduled, so they don't actually show up anywhere else in Epic. We get a phone call that says, hey, this patient's not doing well. They got a CT last night. There's an abscess. We put a drain in him. So he comes to our department, has a procedure done, and then disappears. So this is actually a way to see how many of these procedures we're doing. And again, all that same data with outcomes and tracking of the equipment used and all those types of things. Same things apply. This is also something that has never been shown to actually be a better solution than taking patients back to the OR. Now, it may make sense that if you're avoiding surgery, you know, you don't have to put the patient under general anesthesia. The equipment used is cheaper. The time spent and the people involved is less impact on the hospital, and there's equal, if not better, outcomes for the patient. Then this is a better solution. But nobody's actually ever done the study that shows that using percutaneous catheter drainage is actually better than taking a patient to the OR. And patients still get taken back to the OR for surgical drainage. So if we could enroll other people in this, other institutions to get enough data to show that, you know, comparative effectiveness, this is equal or better than kind of the gold standard, then that would be pretty powerful. So kind of nationally, the Society for Interventional Radiology has a desire to do this type of data gathering and analysis. There's a structured reporting initiative which works off of a system very similar to what I mentioned with the reporting database. So they have structured templated reports that for about 5 different procedures that they're trying to get people to start using those reports, and they built a kind of automated system to send this to some centralized server, and there's about 5 institutions that have signed on. The problem is their structured templated reports are 5 pages long, and getting people to switch from like a single-page report to a 5-page report, it doesn't fit with their normal workflow. It's very, very difficult to do. And then this medical device epidemiology network is another national effort for anything implanted in the body. And so we do stent placements, we do, you know, catheter placements, we place, you know, foreign objects in people, and this epidemiology network is specifically geared towards trying to investigate the long-term outcomes of any of these implants. So we need registries like this to know what was placed in who and when, and how did they do long-term. So what comes next? Well, as I mentioned, now I have to start working on the reporting because I'm actually collecting the data. Standardization of procedural data elements. So, you know, we're an Epic institution. This was built using Epic tools. The nice thing is, if you're the first person on the scene, you get to define your smart data elements, and you can actually suggest them to Epic, and they'll make it part of the foundation or like kind of the baseline installation and push it out to all the other institutions out there. So if I can get it working here and show that it's working and get it on, get Epic to buy into it, then I can make it very easy to actually expand this to other institutions out there. And that's part 3, is getting other people involved and interested, and then perhaps making this a national effort. And that's it. That was pretty quick. Any questions?
Yeah. You kind of come across the conundrum that we always face in informatics with clinicians and trying to collect structured data. How are you handling data that you want to kind of be able to perform reliable measures on, but the clinicians aren't willing or able to, you know, choose the check boxes and things like that that they want? Because, you know, I think one thing we've learned over the last several years is that, you know, physicians don't like to do that, even though that would give us the kind of structured data that we could do all kinds of interesting things with. How have you kind of handled that conundrum?
Well, so one thing that makes it easier is that we're a small department, and right now we're the only people using that smart form, and specifically the people using the smart form are the fellows. And so it's a lot easier for the chairman of the department to tell the fellows, you need to use this, than it is to say to all the attendings, hey, change what you're used to doing and use this structured report. Actually, that's exactly why the structured reporting initiative by the SIR has had such trouble getting off the ground. Not to mention the fact that different institutions use different types of dictation software that can't actually do the structured reporting that they need to be done. So part of it is just, we can actually enforce this on top of the fellows. The other part of it is that, I've really tried hard to make this smart form that we're using as close to the workflow that we were doing before. And at the same time providing benefit to the fellows in that we can automatically gather all your case logging data. You don't have to do this, extra stuff by hand at the end of a long day when you're, not interested in writing down every case that you've done. You just run the report and there it is right in front of you. That's a good question. Certainly we have to show, for fellowship, we have to show how many cases we did, but there's actually no requirements on what the cases were. So doing a complex aortic reconstruction is counted the same as a PICC line. So not yet is the answer to kind of the MOC requirements. But, one could imagine in the future that having this data would be, much more desirable than having to go back and try and recreate it. Yes, yep. Like I said, it's easier because you can force trainees to comply with the data capture method, but I've tried to make it as easy as possible. As it expands to things like outcomes over the long term, then building out additional smart forms to try and capture clinical data, that'll rely more on the attendings. And so I have support of my chairman, which makes it a lot easier. It's almost equal. because it was a lot of typing before and tabbing through each one of those fields. And so it's every bit as easy to click a button. Where I've noticed that there's a little bit more overhead is just I actually have so each one of those procedures you can click on the procedure, and that captures what procedure was performed, and then it drops down a section called procedure details. So that's information that wasn't captured in any way, shape, or form before. So there is a little bit of extra work that needs to be done, but it's just button clicks.
So, okay, in medicine, a lot of people are moving towards using Dragon software for dictations to improve or to decrease the time that we spend with documentation. Is this something that would interface with Dragon at all? Do you know?
You know, I have never worked with the connection of Dragon with Epic, but certainly radiology has been using Dragon for years. We have like one of the most arcane systems here called TalkTech, which is like Dragon 1.0. That's actually one of the problems, though, with trying to get data that way, is people like to dictate the way they like to dictate. And while some of the new, if you've ever seen PowerScribe 360, which is kind of a corollary to Dragon, it actually has click fields that are similar to what you can get in the structured reporting element or structured data elements. There is some ability to do that, but I think the dictation actually yields itself more to, I'm going to do my own thing. NLP would be the solution to that, but I have yet to see an NLP system that can actually faithfully get all the data out. It would be really nice to be able to do that, or just log the times when people are, when is the patient in the room, when was the timeout performed, when is the physician in the room. Haven't gotten there yet. We made the decision as a department, well, I didn't, but when OpTime came online, the decision was made that, the workflow for OpTime was didn't fit very well with interventional radiology, which is kind of too bad now because you collect a lot of great information, just like what you're talking about. And so some of those things are actually we're moving to a new RIS, a radiology information system. It's the Epic RIS called Radiant that actually includes some of those data points. So hopefully these two will work in conjunction with one another, because Radiant doesn't have anything that would replace this. A few things. Case example first. So I think a great case for kind of expansion of this in the future would be something like uterine artery embolization. So there's a procedure that we do. There's a benign tumor called a uterine fibroid, and the procedure that we do basically shuts off the blood supply to the tumor, and we want to see that over time it gets smaller, it shrinks. So the post-procedure note would, again, act as that kind of like timestamp that says the procedure happened on this date and this time with, this kind of material. I'd like a smart form that could be dropped into kind of the follow-up clinic notes, because we know, and actually the SIR has published quality initiatives that say at 6 months, you should see that the tumor has shrunk by 50% in volume. And that should be pretty easy to do, because, I mean, that's a couple button clicks. It's something that I can guarantee you the attending's already looking at the post-operative imaging and dictating in the report. The incentive is just like, you know, here we can actually give you valid information back if you take this extra step. And I think the attendings that would most likely be using that, they're young enough to understand that, I don't mean to insult the older attendings, but they're young enough to understand that, you know, these things are important. And in the future for things like maintenance of certification or, you know, justifying that the procedures we're doing are actually effective and working, we're going to need that kind of data to support ourselves. All right, thank you very much.